Professor Chintamani, you can start.
Yes, please. Let's start.
Good morning. Today we'll have a case discussion on soft tissue sarcoma in the thigh. It's a very common case for DME and MS examination. Dr. Atiq Ahmed is a third-year junior resident at Amputations and Vivekananda Medical Science will present the case. And senior teacher or very beloved teacher, Dr. Chintamani, will take us through this scenario. And Dr. Atiq, you can start the presentation and stop at the end of history. And then you have some discussion and then proceed to examination.
Good morning, sir. I am Dr. Atiq Ahmed, third year PGT. I will be presenting a case of soft tissue sarcoma in the thigh. Mr. X, a 28-year-old gentleman, resident of Shonapur, auto rickshaw driver by occupation, presented to my OPD with the chief complaint of swelling over the medial aspect of right thigh for last 2 years and pain over the swelling for last 3 months. The patient was apparently well 1 year back when he first noticed a swelling, which was on the medial aspect of his right thigh. It was insidious in onset and has gradually progressed from an initial size of 2 into 2 centimeter to attain the present size of 9 into 8 centimeter. The swelling is not associated with any aggravating or relieving factors. He complains of pain in the area of the swelling for the last 3 months. The pain was also insidious in onset and intermittent in nature. The pain was non-progressive, mild in severity, and not radiating or referring to any other area. There was no history suggestive of any metastasis. There was no history of any muscle weakness. Coming to past history, there is no history of any cancer in the past. The history of exposure to any radiation or any toxic chemicals was not present. There was no history of trauma. Patient is not suffering from any chronic disease like hypertension, diabetes, asthma, or COPD. There was no history of exposure to TB, no history of any allergy or any past surgical history. Coming to family history, there is no history of any cancer in the family. Personal history, the patient takes mixed Indian diet, sleep pattern is normal, appetite is normal, normal bowel and bladder functions, he is a known smoker. So I have kept the summary at the last, sir.
Okay. Okay, just wait. Sir, you can have the discussion on history. Yeah. Sir, you are muted.
Sorry about that.
Okay,
I think nice history. And, there are certain points, like when you were describing the pain, you mentioned intermittent pain. What do you mean by that?
The patient is not complaining of pain throughout the day. It is occurring twice or thrice a day without...
That's not called intermittent pain. So don't use the terminology unnecessarily.
Okay, sir.
Intermittent means coming at frequent intervals. Okay.
Yes,
now,
sir.
This is not a pain related to any hollow viscous. So the pain would be related to some exertion or it will happen periodically maybe. So what exactly was the history? You're saying twice or thrice patient
Yes,
had
sir.
pain. That's one.
Yes.
Number two, the onset was gradual or it was suddenly one day he noticed?
No, it was gradual, sir. The pain has, it is severity is mild.
Not the pain. Forget the pain now. Swelling now. Pain, I told you what the problem.
Swelling, he suddenly noticed 1 year back, sir, but it has gradually increased in size since then.
So it's been onset has been sudden and the progress has been gradual. The terms which are very specific. That's why I'm asking.
Okay, sir.
Then about the third thing, when you describe any soft tissue swelling, what makes sense to anybody is, of course, what was the size to begin with and what is the size later on. So what was the size at that time when he noticed first?
It was around 2 into 2 centimeters, sir.
So and then now it's how much?
9 into 8 centimeter.
And it's been how long?
1 year, sir.
So do you think it has been a gradual progress or it is actually multiplied 4 times? So that is a rapid progress. So it is not gradual in the real sense, unless you feel that for the major part of this year, it was gradual and then it became sudden. So what was the history like? Because it's important in soft tissue swelling.
So the patient told that the swelling has gradually increased, not that it has recently increased in size. He said it is increasing over the year to attain the present size, sir.
No, I'm asking you now, in
Yes,
1
sir.
year, if a swelling grows to 5 times its size, is it a
Yes.
gradual progress or it's a rapid progress?
It's a rapid progress, sir.
So you cannot just translate what patient thought in the sense that, he was describing that it happened over a period of 1 year. But for you, you have the duration with you and you have the size with you. So naturally it is multiplied. Now that's about it. While you're talking about the negative history in a swelling involving the limb, now there are few points you covered, but like you mentioned, quickly you went down to no history of metastasis, no history of any muscle weakness. Now that is a muscle weakness. What do you mean by muscle weakness?
The power of the muscles. So the patient has no difficulty while walking or standing, and I check the power of the
So,
muscles.
sir, this is not called muscle weakness. Now, that is why, there are terms which are very specific. So there is no history suggestive of any neurovascular, neuromuscular deficit. That's what you're saying?
Yes.
Yes.
Okay, I'm just correcting it for you because you cannot just use the terms loosely. Muscle weakness is a very loose term, although I understand what you're trying to say. Okay, now maybe some points we're missing here, but then let's move to the next part of the history. Now, when you're saying no history of metastasis, there is no such term as no history of metastasis. The term is distant metastasis. So no history suggests of any distant metastasis. And which is the most common site for limb sarcomas? Can you hear me?
Lungs, sir. Yes, sir, I can hear you.
So
Lungs,
when
sir.
lungs you're saying, so you can be specific in scoring a mark there. So there is no history suggestive of any distant metastasis. It's like
Respiratory distress, sir, cough, hemoptysis.
And it's not respiratory distress, again a wrong term used. Distress comes with a cardiovascular disorder. So no history of difficulty. No history suggestive of any chest or the lungs involvement, which can be in the form of effusion or hemoptysis. So that is what you were trying to basically say. So no history of any muscle weakness doesn't make sense. Similarly, no history of any bone pains or any associated complaints that will come through. Okay. Now, next slide is your family history.
Past history. Okay.
Past history. Now, there is no history of any cancer in the past. Okay. Now, there is no past history of any cancer. That's what you're saying. I understand. Why did you want to take that?
Because in some childhood cancers, a radiation like lymphoma, the patient can get radiation, which is a risk factor.
To take a history of secondary cancers. That's a specific answer. And no history of any exposure to radiation or toxic material. You try to look at the etiology of it now. Yes. And no history of trauma, which would come before cancer. So trauma is a very important history, which is common. And history of any cancer, he would not forget to mention. Okay, so there is no history of trauma. There is no history suggestive of any cancer in the past or treatment with the radiation or exposure to any toxic chemicals. Right? The rest is okay because no surgical history. Coming to family history, next one. What were you looking for? No history of any cancer in the family. How would he know unless you specifically ask? So what did you want to ask actually?
I wanted to ask if any there is any history of any colon cancers or adenomatous polyposis or any childhood retinoblastomas that run in the family that the patient might know of. Any genetic association, sir? Because
which malignancy, which familial scenarios like?
So, like in neurofibromatosis, Gardner
Name
syndrome.
The conditions which are genetically linked with soft tissue sarcomas.
Yes, sir. Retinoblastomas.
Otherwise, okay. So Gardner,
neurofibromatosis.
Live from any syndrome, and also retinoblastoma associated with what gene you're talking about?
Lafremin is P53 gene, sir. Retinoblastoma is RB1 gene, and neurofibromatosis is NF1 gene, and Gardner syndrome is APC gene, sir.
So you knew the answer, so you can be more bold about it so that you score your marks. Okay. Now, family history in any cancer is a very specific question that you ask the patient. Otherwise, it look like you're very casually just taken a history if anyone got cancer in the family, the patient may not be able to tell you. And many a times they don't understand it is cancer. Okay, so it's possible that they got their, some first cousin or the brother or sister getting treated for retinoblastoma. They may not even know it's a eye problem, right?
Yes.
And next slide. Now this is generally okay. Although for a swelling of this size, patient being completely asymptomatic, it's slightly difficult to stomach. But patients do have resilience and they continue to walk. If you say he was completely without pain on walking, so therefore that pain would need to be qualified, whether it is associated with walking or exertion. Or you mentioned that there's no neuromuscular deficit, which you did mention.
Yes, sir.
The rest, I think I'm okay with the history. And remember, most of these swellings appear without any symptoms. They keep silent for a very long time. Therefore, the patient has to be specifically asked, and you have to elaborate on history, right?
Okay, sir.
I think we can move to examination if Dr. Shah agrees.
Yes, you said the neurovascular compromise. What may be the symptoms of vascular compression or compromise?
So the patient may have lymphedema or a decreased edema of the lower
Suppose
limb as a whole.
there is venous compression.
Venous compression, lymphedema,
what
not lymphedema, edema of the lower limb, swelling of the lower limb, sir.
And
You see, Dr. Shah has asked you a very specific question. And again, when he asked for neurovascular, he started by saying lymphedema. So what is a neurovascular first? It's the nerves,
Nerves, sir.
then vascular, right? So patient may have what symptoms? That's what he's asking you.
Due to compression of the, it depends on the nerve involved.
Before I compress you, Ati, I'll irritate you.
Yes, sir. The tingling, yes.
So be specific. We don't be completely, it will completely include it or compress it or encase it later. Initially, it will irritate the nerve. So finish the, you answer that. Completely answer.
So the patient will have tingling sensations over his feet. The patient may show weakness in the movements, and it can lead to ultimately in foot drops if sciatic nerve is involved.
So postgraduate should be more precise in asking. So it is initially paresthesia or hyperesthesia or root pains or carried pains like conducted along the, or what we call as neuritic pains, followed by the extent that you mentioned in the form of foot drop or weakness in the limb, muscle weakness. And then, as was mentioned, venous compression can lead to a pitting kind of edema, but lymphatic is rare, in especially soft tissue sarcomas. It will generally, you can't compress on lymphatics. You can, the lymph nodes get involved. That's when the blockade can happen. So you could be more specific. Is that fine, Dr. Shah, or you?
Yes, sir. You can pass on to the examination.
Examination, please.
Yes, presented well. That history is good.
Yeah.
Coming to physical examination, general survey. With his verbal consent, the patient was examined in a well-lit room. The patient was well oriented to time, place, and person. The patient was examined in supine position. According to Karnofsky scale, the performance status of the patient was 90. BMI 20 with no clinical evidence of any vitamin deficiencies. The patient was well hydrated. No pallor, icterus, clubbing, cyanosis of pedal edema or engorged migrants were noted. There was no regional or generalized lymphadenopathy. The gait of the patient was normal. Vitals were stable in this patient. Coming to examination.
I'll just stop you there.
Okay, sorry, sir.
I think it's a common mistake with most residents when they describe the performance status in a patient with a problem of the limb. You see, because of the tumor and the size that you mentioned, he can't be walking normally. So it is not going to be 90 anytime.
Yes, 90 is minor symptoms.
So don't unnecessarily fall into that trap, because you can't comment on it. When the patient has pain, how will you walk? Isn't it? So it is not always necessary. So if you can go for ECOG, and or you can qualify by saying that patient would be around 80 at least, because you can't have this patient with minor complaint, right? So it should be, so you should be careful with that. I noticed that this is common common error that we observe. It's everywhere. My residents do the same mistake. That's why I thought I'll let you know. Could the gait be normal if he's having pain while walking? You see, you are just buying trouble because patient is having pain or patient is able to walk like you walk.
No, sir. He was.
What you're trying to say is that gait is normal in the sense that there is no involvement of the joint or patient doesn't have any. But it is not going to make sense because if the patient has pain, he'll limp.
Yes.
Every patient with pain will limp. So it is more important that you honestly check for it rather than just mentioning theoretically, because you assumed this is just an class, so you can be told as to where you went wrong. You can't be unnecessarily completing the checklist by saying I took this history, I examined this, I examined this. Certain things cannot be correctly understood. See, no pallor, icterus, clubbing, cyanosis, pedal edema, gauze, neck waist, all right. There was no regional or generalized nephropathy, all right. The gait, you think yourself, and you are the one who has examined the patient. Was he walking normally or not? With a swelling of that size, it's quite unusual. Therefore, don't just insist on certain things like I mentioned about the performance status and the gait. Okay, let's move.
Examination of lower limbs. Inspection. The examination of the left lower limb was normal. There was a visible swelling over the medial aspect of right thigh of size 9 into 8 centimeter. It was ovoid in shape. The skin over the swelling appeared normal without any signs of inflammation. No scar or previous histological exam was present. No swelling of the limb distal to the thigh was noted. Palpation. The left lower limb felt normal on palpation. There is a swelling on the medial aspect of right thigh, which felt warmer to touch than the surrounding area and the opposite limb. It was of the size 9 into 8 centimeter, ovoid in shape, has a smooth surface. The margins were regular and palpable all around. It was hard in consistency, non-tender. The swelling was not fixed to the skin, but was fixed to the underlying muscle. No distal neurovascular deficit was noted. Systemic examinations were normal. There was a CNS examination has no focal deficits. Spine examination was also normal in this patient. Coming to abdominal examination, there was no distension or hepatomegaly noted. So, shall I summarize?
Yeah, of course.
To summarize, a 28-year-old gentleman, normotensive, non-diabetic, presented with a swelling over the right thigh, which gradually increased in size over the last year to attain the present size of 9 into 8 centimeter, with complaint of pain in the swelling for the last 3 months. There is no associated skin changes over the swelling, weakness of the limb, or lymphedema distal to the swelling. There was no history of any metastatic symptoms. On physical examination, general survey was normal. On examination of the lower limb, a 9 into 8 centimeter swelling over the medial aspect of right thigh was noted. The swelling was firm, non-tender, ovoid in shape, and with well-defined margins and fixed to the underlying muscle. There was no regional or generalized lymphadenopathy, no distal neurovascular deficit noted. Systemic examination was normal.
Which underlying muscle you are referring to?
So the swelling was present in the medial compartment, sir.
Do you have a picture to show?
No, sir.
You don't have a picture of the case. So, which muscles you tested for?
So medial compartment, it is the adductor compartment. So adductor, the muscles present in the that compartment are adductor longus, adductor brevis, adductor.
How did you test for the adductors fixity?
So we first I will examine the patient in relaxed position by I will hold the swelling and move, and I will try to move it both perpendicular and along the axis of the muscle. Then I will ask the patient to contract that muscle, and I will check the muscle whether it is contracted or not.
How do you contract the adductors?
So I will ask the so I will ask the patient to I will press my hands over the knee and ask the patient to push against internally, so on the inside.
Yes. Adduction against resistance.
Actually, see, the question is very straight. So whether it is in the upper limb, lower limb, neck, or wherever, the answer comes very obviously, spontaneously.
Yes.
You make the muscle go against resistance. So you, when you're testing for adductors, abduct and ask the patient to adduct now. But what is it that you need to do? You need to stabilize the patient's hip and the spine. Otherwise, the patient will turn over.
Yes.
That's one thing you need to do. Suppose you're doing it below knee, you need to stabilize the knee, the joint above and joint below. It's important to understand. I was trying to check. I don't know whether you've done the test or not. Because if you've done the test, then you can probably understand what I'm just mentioning.
Yes.
The important thing is, if it is fixed, we have a totally different approach to the case. And if it is not fixed, we know where it is lying. So if I was to ask you the plane of the swelling, where is the swelling lying?
So this, as the swelling appears fixed to the muscle, I will say it lie deep to the deep fascia, sir.
It lies deep to the deep fascia.
In the muscle plate.
That's okay. I mean, deep to deep fascia does for us. In terms of the the compartment involved, you're saying it's the adductor compartment that is
Medial. Yes, sir.
am I right?
Yes.
So which neurovascular deficit you were looking for? Which specific structures you had in mind?
So it generally adductor compartment, the nerve is the nerve supplying it is the obturator nerve, sir. So
what symptoms will the patient have? Suppose obturator is involved.
I
See, therefore, I mean, if you eyes will see what the mind knows. So, is there any relationship of the referred pain to knee from irritation of the have you heard of Romberg sign here?
Yes, sir.
What is that? Forget about the posterior column, but here in the hip, if it's irritated, you have the pain in the knee. So then patient will have numbness or tingling alongside. Okay.
Yes, sir.
And where does it lie? The operator foci comes down. You can cover because we have just 1 hour to finish, right?
Yes.
And examination in a patient with the limb sarcoma is the key. You are not going to discuss the the very minute aspects of it, because that you can always read, but clinical examination would be very, very important. And you should be able to examine the limb as a whole. Now, was there, how did you look for, how did you arrive at the conclusion that there is no neurological deficit? Forget the vascular deficit, that is easier.
So the patient was able to move his limb. There was no no difficulty in mobility, and the touch sensations, touch pain sensations were on normal, so for this patient.
And what about the muscle bulk? You said there is no wasting. So which one muscles you measured?
So the lower limb, the calf muscles did not appear wasted, sir, and also I
how
could not
did
properly
you look for the wasting?
So by measuring the circumference and comparing with the opposite limb, sir.
See, the tragedy of this new pattern of examinations, especially now with DNB, where you are just OSCE-based exams, you people try to skip the clinical examination, which is the key to understanding. And let me assure you that pattern of examination will change because nobody is happy with it. It's not able to examine the patient, the candidate completely. So you just picked up some points, and if I was to examine you for this case, I'll ask you to examine the limb. I will not be bothered about the theoretical discussion, which will follow. We'll take care of that. But important to understand. And with such a large swelling, patient won't be using the limb so easily. There'll be some bit of wasting. So since there is no picture, I can't really challenge you. Suppose
yes,
you're looking for
and more so, sir, and more so, he says it's confined to the adductor compartment. It's swelling of 10 centimeter size.
Then
definitely
how will
not
it
the quadriceps lobe of muscle. It will definitely
absolutely. If it was involving, suppose Atik, it's a brilliant point that Dr. Shah has brought out. If it was such a large swelling, and if it remains confined to the adductor compartment, it will have to produce some distal features. No, it can be kept confined tightly,
yes,
but then it will have the features of some bit of neurological deficits. So therefore, some statements somewhere may not be right. I know you people are now adopted to just patient being on a paper, so that can be an issue. Please go back and check and examine your patient adequately. Okay?
Yes, sir.
Right?
We'll be going back to physical cases very soon.
Yeah, I think, and there, Dr. Shah, they are looking at changing it because It was brought in with, I think, COVID in mind. Now they're wanting to do it again to the old pattern because that is what is going to make it a classical examination. I'm sure you
Yes,
will
sir.
agree.
Yes, sir.
Yeah. Let's see now. You're giving us a diagnosis.
Yes,
Yeah.
sir.
Keep to time.
A 28-year-old gentleman with a soft tissue swelling in the medial compartment of the right thigh, probably a soft tissue tumor, likely a sarcoma.
Well, this is the part you people have mastered now, so I won't bother you. But you know the problem that I was talking about. So you're good at the beginning and you're good at the end. It's the middle part which is a problem, and that's where the goof up happens. There are certain terms which have their meaning. And when you're saying no neurovascular deficit, you better be sure you've checked for everything, okay? And I'm not trying, you made a good presentation and you've done best in the provided circumstances, but you should go back to checking it. Now, I have no problem with him being a 28-year gentleman. That is fine. You know him better than I know, so he must be a gentleman. Soft tissue swelling in the medial compartment of right thigh, probably a soft tissue tumor, likely a sarcoma. It's very nicely put. And is it possible to give a clinical stage?
Yes, sir. T2N0M0, sir. The swelling
Your
is
answer should have been no, sir, because I would like to know the grade.
great,
So
sir.
I deliberately asked you just to poke you. And then you can always say that minus the grade, this is my stage. Because in sarcomas, it's a very important way to look at it. What is the AJCC 8th edition change or changes that we have got in soft tissue sarcomas now? 1 to 3.
Yes, T3, T4 are added, sir. For TX is the tumor size could not be assessed. T1 is less than 5 centimeters, less than equal to 5
5,
centimeters.
10, 15. All right,
5,
let's
10.
move. Don't waste time.
Okay, so
And about notes being absent or present, distant
N0,
medicine being absent or present.
N0 and
Fine.
M1. sir.
N0, N1, M0, M1.
Regional nodes is
Simple,
N0. Yes.
right? So with regional lymph nodes, what happens to the overall stage?
Stage 4, sir. For extremity sarcomas, it shifts to stage 4, sir.
Yeah. So metastatic. So, and then they've divided based on where the location is. So it's the site. And now, what are the negative features in your patient which make this a bad soft tissue sarcoma?
Fixity to the skin, sir. Fixity to the underlying muscle, sir.
You finish.
No, sorry, sir. Size of the tumor, sir. It's a large.
Don't get lost. Remember, size, site, depth. SSD, and then the rest. So SSDR.
Size of the tumor is more than 5 centimeters, sir, and it is deep to the deep fascia, so it's a deep tumor, sir. And it was ovoid in shape, not irregular margin, so that is not a negative.
Earlier deep to deep fascia. Earlier, deep to deep fascia was taken as a staging parameter.
Now we don't. Now, why have they removed it? Any idea, Atik? They've mentioned it there because actually, if there is a soft tissue tumor superficial to deep fascia, which goes through the deep fascia, you won't be able to notice. And the distant metastases are known to happen with deeper tumors. Now, you said there is no regional lymphadenopathy.
Yes.
Which soft tissue sarcomas are associated with regional lymphadenopathy?
It's rare, sir, but the synovial sarcomas, clear cell sarcoma, alveolar sarcoma, embryonal sarcoma, Ewing sarcoma, and rhabdomyosarcoma sarcoma are generally associated with.
You should have started with
rhabdomyosarcoma sarcoma. It's the most common.
So don't start with the rare ones. Okay. Synovial sarcoma, can it occur in the thigh?
Usually occurs in the knee joints, near the knee joint.
So why is it called synovial sarcoma?
So it's a misnomer, sir. It does not arise from the.
It has nothing to do with synovium.
Yes, sir.
It is just that the tumor the cells look like the synovial, the features. So it is not. So it is not related to any joint. So don't get confused. So it's not because it happens at the joint. It will happen around it. But importantly, it is the involvement of the muscles, right?
Yes.
So if you were to looking at grading it or looking at making it slightly better. Can you give it some stage, mentioning that pending the grade, I'll add it. And how do the grades contribute to the stage?
Grade intermediate and a high grade shifts the tumors to stage 2, 3, and 4. Sir.
Yeah. So how do you grade them?
Oh, there's two grading systems, FNCLCC systems and NIH system. As per FNCLCC system, the three parameters are taken. Those are the mitotic number of mitosis, necrosis, and tumor differentiation. And scoring is from 2 to 8. Sir. So 2 and 3 is G1, that is a low grade. 4 and 5 is intermediate grade, that is G2, and G3 is 6, 7, 8. Sir.
Good. So you will eventually go for GTNM. That is what your answer should be. Now, is there a differential diagnosis, or that's the end of it?
Sir, I would have considered lipoma if the tumor was soft, sir, and hematoma if there was a positive history of a trauma. But as they are not present, I do not have any differentials. Sir. This is my.
So you could start by saying I do not have any differentials rather than saying it at the end. Okay. In view of the following features, okay, which you mentioned. So I would not waste your time on that. Now, this is your working diagnosis, and I agree with it because I will not be surprised. That's the most likely diagnosis. What makes you think it's a soft tissue sarcoma?
So generally all large tumors that arise from the muscle plane are considered to be soft tissue sarcomas until and unless proven otherwise. Sir. And,
good, and especially in the extremities.
Especially in the extremity. And the second, sir, it is fixed to the underlying muscle, sir, and there is a history of pain for the last 3 months, and also it's a rapidly growing tumor, sir.
So you have again put it upside down. So in points in history and points on examination. Otherwise you will be messing it up. Points in history is the way it appeared de novo. We all know that lipomas don't change into liposarcomas, benign tumors don't become malignant, but they can be, they arise de novo, and then there is a rapid progress in history. Painless it has become painful. That's in history. Okay, on examination, there's a hard swelling with fixity to the deeper muscles, and there are, of course, there is no neurovascular deficits, which is, of course, another point. So by and large, it will be suggestive of it being a malignancy unless proven otherwise. I agree with you. How do you proceed now?
So I will do some investigations to confirm my diagnosis, some to stage the disease, and then some investigations for the treatment. To confirm my diagnosis, I will do a radiological investigation. I would want to do a MRI of the extremity, followed by a cord needle biopsy from the tumor, sir, to stage the disease. I will be needing the biopsy results and the MRI findings and the grading of the tumor to stage the disease, sir.
Okay, so I'll just correct it for you. Investigations to confirm the diagnosis certainly do include imaging first, and a lot of people like to do an ultrasound guided core needle biopsy rather than just core needle biopsy. So that's one answer which I would like to differ from you, that it should be image guided, because especially in soft tissue sarcomas, you can go wrong. And suppose it is an equivocal diagnosis on core biopsy, what do you do next?
So I will try to do core biopsy second time. If I fail twice, then I will go for an incisional biopsy, sir.
So if you have to plan incisional biopsy after 2 failures, what precaution you would take?
It should be generally, it should be done in the center where the definitive operation is going to occur, and by the same team who will perform the definitive surgery. Being an extremity, the incision should be a longitudinal incision. Minimal dissection should be done. That is to say that the skin flaps should not be raised. Hemostasis should be controlled, sir, to prevent a tumor spread via to different other planes, sir. And
you see, everybody keeps talking about this seedling with the blood bleeding and the metastasis, although there's no proof to say that. But more importantly, it will affect your further imaging because it will leave an artifact. And you don't breach more than one plane at a time. So you should not go in 2 different directions. So it's not the center, as you said, it's the apex.
most prominent point.
The word is the apex of the swelling. So take it from the apex, and you will take it in a manner that if you want to go for surgical excision, include that scar in your excisional incision. And also don't raise the flaps because you don't want to breach the planes. That is the whole idea, and you should be able to highlight that. And before that, you would like to do an imaging, and MRI is the gold standard. Workhorse is MRI. When do you need a CT in soft tissue sarcomas?
So if it's a large, it's a T2 or more than 5 centimeter tumor and higher grade, then we will do a CT chest, sir, and to
CT for the primary.
Okay, CT for the primary. If the MRI is not available and the patient cannot afford, then I will do a CT. Sir, or
So the answer is CT is indicated in soft tissue sarcomas involving the abdomen. So usually retroperitoneal sarcomas or intraperitoneal sarcomas.
Yes, sir.
Otherwise, the gold standard is MRI. And the CT can give you information, but there is limited role of X-rays. Although a lot of old-time examiners would like to hear that to exclude the involvement of the bone, because sometimes the good digital X-ray you are able to exclude it, but nothing much. You can just see periosteal erosion, etc., and those features. So MRI is the gold standard, and CT is usually for metastatic workup. So CT thorax, it's done for all tumors more than 5 centimeter. You're correct. And anything to do with the grade you mentioned, G2, all G2s, you do that. G2 and above. So you've done an MRI, you've done a core biopsy. Which is the most likely soft tissue sarcoma expected here?
Liposarcoma.
Okay, and?
Liposarcoma and undifferentiated sarcoma. MFS.
Yes, MFS. And actually, that is more common. Therefore, you should include it. It depends, of course. Lipos are more common, yes, in the extremity, especially the thigh and also in the retroperitoneum and other places. But that's all right. You know, what percentage of cancers are soft tissue tumors, sarcomas?
In adults, it comprises only 1%, but in childhood population, approximately 7%. Sir.
These you mug up quickly. And which is the most common in childhood?
Rhabdomyosarcoma.
So to consider that in your understanding, I mean, that's why I was saying you mentioned that at the end as a one which produces lymph node metastasis, but it's one of the common ones. Great. So we have a working diagnosis, and you will rely on the pathologist for giving you your grade, and then you can have a GT and M classification. Now, how do you proceed and what do you do?
And what about, sir, ISC? Because histology cannot give a complete diagnosis in all subtypes.
Yeah, most types it cannot. And yes, Atik, what you mentioned, 1% are the soft tissue sarcomas. And do you know there are 100 subtypes of this one?
Yes, sir.
So they may not be able to give you in each time with the core biopsy. If they're very clever, they can. And does it change your management? That is why it is important.
No, sir, not exactly, because if my ultimate management will be surgical excision, so that is a wide local excision of the tumor, sir.
There are some tumors where there is a case for putting on neoadjuvant or otherwise chemotherapy.
Yes.
So they do change it, but provided you get the diagnosis or you get the immunohistochemistry done by somebody who is really sharp at it. Now, in which cases you would like to, rather than surgery, go for chemotherapy first?
So for rhabdomyosarcoma, we'll
so you know it, no? And also, what about Ewing's?
Ewing's, yes, sir.
So it depends at what age you get what tumor, and then immunohistochemistry can guide you towards your planning of the treatment, right? And how do you plan the treatment for this?
So we'll plan a wide local excision, sir, followed by adjuvant.
So I would give you nothing for that, because always remember, all cancers must be discussed in an MDT. Now, and if you're interested on YouTube, we have put at least 6 of our MDTs. You can watch them. So all decisions now we take, there are about 8 to 10 tumors cancers discussed, so that especially in soft tissue sarcomas, because so many people are involved in it. Although it's a surgical disease, I agree with you. And it is often said that the surgeon gives the therapy in 2 hours the radiation oncologist gives it in 2 months, and the medical oncologist gives it in 6 months. So in those 2 hours, you can actually give patient PCR, as they call it. Surgery is the best PCR if you get clear margins. Correct? So the plan is multimodality approach. So we will have a discussion in the multimodality team. So MDMs, multimodality meetings. And suppose you've decided we are going for surgery. You have not given us the picture, otherwise I would have asked you as to how do you go about it. Is it really hard to take pictures these days? I think COVID is gone. So you should be encouraged into presenting with pictures, so that in fact videos. And let's move. What do you do now? Is there any case for putting this patient on neoadjuvant chemotherapy, one which is the rhabdo or
even so generally if there are few advantages of putting
no,
the patient.
I'm asking you the indications, not advantages.
So, the tumor more
You
than
said
5
it fits to the muscle. You said it fits to the
Yeah,
muscle.
Yes,
so you're not thinking, so you're more interested in rattling out the air. So when it is fixed to the muscle and fixed, suppose that obviously the answer, the copybook answer is large tumors with involvement of neurovascular bundle of the joint, where you want to do lymph preservation, okay, and you're not likely to get an R0 resection, then you'll have to put the patient on neoadjuvant chemotherapy. That's what we do. And what regime is used?
Adriamycin and
You're all right. Doxorubicin based.
doxorubicin based and phosphomycin. Dacarbazine is used.
And some people, some, yeah. So isofamide and doxorubicin and mixture of these.
Yes.
So neoadjuvant. What are the other advantages? Some people, I'm just going away, deviating from the topic to get back and taking a detour. Indications for neoadjuvant chemotherapy, as I mentioned, where you're not likely to get a clear margin, or it's fixed to the neurovascular bundle or to the joint, which you need to preserve. For lymph preservation, patient doesn't give you consent for amputation. So these are the indications. And there are some tumors where which melt, like rhabdo can melt. They can respond to chemotherapy very well. Any indications for neoadjuvant radiation?
Neoadjuvant radiation. So,
Will this patient require post-op radiation?
this patient got post-op.
Post-op is required. Is it what to give pre-op?
So we can it's a vascular tumor, so preoperative. If we give the response,
I think the question was very specific. There are indications, right? More than 10 centimeters, some people give it in their MDTs. Retroperitoneal sarcomas, some people give it. Extremity sarcomas, for the same reason which I mentioned. And upfront radiation acts better because of the oxygenated tissue, and the radiation oncologist doesn't have to search for where to give radiation, because post-surgery, it's all scar tissue, which is involving all the surrounding vessels. So collateral damage is more. So there is one, there are some studies, and there's one from Toronto, which has shown definite advantage at, not in terms of overall survival, but in terms of recurrence-free survival, because of the same reason, right? What you're giving in an adjuvant setting, if you give in a new adjuvant setting, there is an advantage, but they were balancing it against the local complications of wound-related problems, like the flap failure, etc. So they were not able to. Surgery upfront is the best option in these cases. You should be clear. In retroperitoneal sarcoma, it's a separate situation. You may not get R0 in most cases. Mountain, like when the valleys can be ignored, and when you remove the mountain, you'll be giving radiation to the valley, and you'll damage all the structures which are so the collateral damage is the reason. And remember, for neoadjuvant chemotherapy in soft tissue sarcomas, the other reason why they recommend it is because you can get an in vivo chemosensitivity test. Same thing applies for intraoperative radiation versus And neoadjuvant radiation, intraoperative radiation versus adjuvant. The adjuvant radiation is not a routine. Adjuvant radiation is not given to all tumors, right? So we will come to that. What surgery would you offer to this patient?
Wide local excision, sir, with 1 to 2 centimeter of the tumor margin, sir.
1 to 2 is a very loose term, no? What is the recommendation? Most books say 1 centimeter, but yes, you're right. I take 2 centimeters so that I can get 1 centimeter of the pathological margin, because the tissue is stretched and other things happen. And what are the barriers you consider?
The thin barriers, the barriers that I consider are adventitia of the blood vessels, the periosteum of the bone, sir, and perineurium, sir. So the barriers. And the fascia of the muscle, sir.
So you can actually take out the muscle. In this case, the compartment has to go completely. So some people may call it loosely compartmental excision, which is not required these days. You just can get a wide local excision, which is what most people do. And that would mean, why should we go wider in soft tissue sarcomas?
So soft tissue sarcomas is an expansile disease, so it generally grows along the plane and does not invades. Invasion is less, so wide local excision is preferred. And the chances of recurrence is very high, so if we do not achieve R0 clearance.
The trick to doing a good 3-dimensional tumor, like radical nephrectomy. Yeah, you should not see the tumor at all around. Okay. All around. And remember, there are some tumors, you're right, which grow along the planes, like myxoid fibrosarcoma. There, the role of neoadjuvant chemo, neoadjuvant radiation is been highlighted further. And also soft tissue sarcomas involving the head and neck, and also in the prostate and perineal region. They're rare. So by and large, surgery up front, right? Yes. And what do you do for the muscles that you remove? Do you reconstruct?
So muscle, yes, so we can
have you seen this surgery when this patient was operated?
Sir, it was not operated in our center. It was referred to higher center, sir.
Higher than your center? So yes, patient went to the moon or what?
No, sir. Sent to a cancer institute, sir.
All right. So usually, when there's no shame in it, if it is not done, then it should go to the right place. The plane is 1 plane deeper and around 1 plane. Deeper you go, take out the muscle compartment. So I'll be going above the tumor, entering into the medial compartment muscles and just dissecting the muscles out. So you would not be able to see. All around you should get a clear margin. And you leave clips in the tumor bed for the boost and the radiation.
Yes.
And what are the indications for radiation?
So tumor size more than 5 centimeters, sir. Deep, high grade or intermediate grade tumors, sir, and
recurrent.
Deep tumors, sir.
And recurrent.
Recurrent.
Don't forget that. The important thing is, when you're doing this surgery, you will make it a point that you orient the specimen and you roll a frozen section.
No, sir.
There is a roll of frozen section, especially in those patients where you have a lymph node involvement. And also, if you have a doubtful margin, you're close to or you're shaved. When you're shaved, the barrier, just the barrier can be examined, and you can even take a cavity shave from that barrier. So you can take a chip of bone, just chip of bone to see. So that's very important because it changes your complete management. Okay, and especially for extremity tumors that are lying next to the bone, giving upfront radiation can cause the problem to the bone also. They can fracture. So it is important that you don't give answers without discussing in the, you will mention that I'll discuss it in the MDT and I'll get the best treatment for a particular patient. In soft tissue sarcoma, it has to be tailored. And as Dr. Shah also mentioned, you need to know the immunohistochemistry very well to plan your therapy accurately for future. And yes, if you remove a major chunk, more than 1 compartment, you need to reconstruct. Because as it is, he's not using this muscle, so his rehabilitation, he cannot become absolutely normal. But you would like to cover what you remove in cases where you need to provide the patient with, good recovery or rehabilitation. Remember, when you're answering, you should have a clear-headed approach to it, that we are looking at doing a limb preservation surgery in this patient, and those parts would be automatically then covered. What is the role of other adjuvant therapies for this patient?
Other adjuvant therapies.
Any role of immunotherapy, any role of isolated limb perfusion therapy?
Isolated limb perfusion therapy can be tried in patients who want to undergo limb salvage surgery, sir. In this case, there is a role of isolated limb perfusion is generally done for locally advanced and recurrent tumors.
Metastatic and metastatic. And rarely would it be done. And what is the drug used?
So in some literature it is written melphalan and cisplatin, but I have also studied that melphalan, if TNF alpha and interferon gamma can also be given together.
The immunotherapy can also be used alongside. And you should just read about it. You should be aware of it. I'm not going to get into the depth of it. The idea is isolate the limb by putting a tourniquet and have a reverse flow of the therapy. And the limb gets the maximum dose. Okay. And also be clear on intraoperative radiotherapy. It's very effective in brachytherapy is very effective in these tumors, especially in the extremities, because you can put the device very easily and you can get lower dose. And if you give the other advantage of radiation in a neoadjuvant setting is you can do with lower dose rather than, yeah. So these are some advantages, but not very effective because it's essentially a surgical disease, and that's how you should remember it. Do you have any question? You don't have any question? Dr. Shah, are we done?
Any indication for amputation in limb sarcoma?
So yes, if there is involvement of neurovascular bundles and we will not be able to provide a functional
I think he's asked you a specific question. Yeah, he's asked you a specific question, indications for amputations. Your answer would be what? First of all, it's a rule of three. Remember that. Rule of three is neurovascular, the nerves, vessels, and joint. If any two are involved, the limb cannot be salvaged because you cannot salvage it. So if you cannot salvage the limb, what is the option?
We'll go for either neoadjuvant radiotherapy or amputation.
If you have to do amputation in this patient, will it be amputation or disarticulation?
Amputation.
Okay, it will depend. Suppose this patient had a lymph node.
Yes, sir.
In the inguinal region. What would you have done differently?
So, along with wide local excision, we would have done a inguinal lymphadenectomy, a radical lymphadenectomy of the inguinal region.
I wanted you to say that so that I can tell you we don't do that. So, first of all, we would have gone back in time.
USG of the lymph nodes.
Guided FNA or 4 biopsy.
USG guided FNAC.
If it is positive, then is there any advantage of lymph node dissection? Is there any advantage in terms of lymph node dissection?
Because it's a metastatic disease now.
It's a metastatic disease.
It should be a adjuvant therapy only.
Chemotherapy.
Therefore, there is no indication. Yeah, you will give chemotherapy. And in fact, neoadjuvant you can take. That won't be neoadjuvant chemotherapy because you are doing it in a metastatic setting. So you'll be doing primary chemotherapy because now we know that positive node would be an M1 disease. No, it's a metastatic disease. So you should be clear that this patient won't require any locally aggressive treatment. Other indications for amputation.
So if we are not able to provide a functional limb or a limb that is better than its counterpart with prosthesis, then we'll do a amputation, sir. And if it's a diseased limb, that is a limb already has a lymphedema, then we will opt for amputation, sir.
If there was a lymphedema in the background of a lymphedema, which sarcoma is developed?
Angiosarcoma, sir.
How do they present? What is the typical presentation? They're extremely painful. That's one. And there are some of these hemangiopericytomas, etc. They lead to a bleeding limb. Then the limb can't be salvaged. And you answered it very nicely. That is what you discuss in an MDT. Is it going to be a functional limb or you will be happier with a prosthesis? And there are some very decent prosthesis available now with articulating joints in it within them. So be clear on that. Right, Dr. Shah? Anything
Yes, sir.
more?
Thank you.
Yeah.
No, fully covered. If someone can answer this part, he's through. Thank you. Yes, presented very well. Dr. Atik, your presentation was good and you are
And I
very
think
well.
it's through.
Thanks.
You passed. Right, keep it up, keep preparing, and next time present with a picture and try to go back and see your patient also, what happened to the patient. Okay. Now, Dr. Shah, do I have your permission to quit?
Okay, sir. Thank you, sir.
Excuse me, sir.
Thank you all very
Thank you very much, sir.
Yes, please.
Sir,
Somebody said, excuse me.
Yes, yes.
Yeah.
sir,
Yes,
history of trauma should be included in history of presenting illness as negative history, sir.
Yes,
Yes.
actually, trauma is not the etiological factor, but often trauma brings notice to a swelling. So, trauma is not.
And one more thing, Dr. Shah, you are absolutely right. It may not be, but sometimes it's just a big hematoma, which can undergo a change towards desmoid. But as rightly said, it will draw attention to swelling, which you otherwise did not notice. But history of trauma has to be taken as a negative history.
Okay, sir. It should be mentioned in history of presenting illness, not in the past history, sir. Or taken in both, sir.
Well, now listen, you're trying to put a thread in a needle, so it will go either the needle goes to the thread or thread goes to the needle. If you've taken it once, you won't take it twice, no. But it makes more sense in history of present illness, because that's where you're trying to highlight that trauma can draw attention, and rarely the hematomas, as yet kept also as a differential. Sometimes hematomas can get calcified and they present as a hard swelling, which will make me confused with a soft tissue tumor. So it's an important history. Okay.
So in history of present illness, you can say that there is no history of preceding trauma.
Yeah, no history of preceding trauma. And once you have said it, there is no point saying it in past history, because some trauma would have happened definitely. To say nobody had no trauma in life, physical, emotional, mental, very, very difficult. So trauma history is always present. Right then. Thank you very much. Have a great day, Doctor.
Thank you.
Bye-bye.
Thank you, sir.
Pleasure.
Thank you, Atik.
Thank you, sir. Thank you so much.